very good morning, one and all. Welcome you all for the UVA session Drishti 2025, Uveitis X-Files. Here we have a case presentation based IC. We have 4 interesting cases will be presented by eminent Uveitis specialists, and we also have 2 expert panelists. First we have Dr. Anuradha VK, known to all of you. She is head of the department, Uveitis department, Coimbatore Aravind Hospital. And we also have Dr. Archana Pradeep from Nottingham, UK. So let us start our session without any delay. First, I invite Dr. Needu Pradeep for her case of iris nodule. Needu here.
Good morning, everyone. Let's see what is behind the iris nodule. We have a 68-year-old man coming with defective vision in right eye for 4 months duration. Best corrected visual acuity was 636 parts and left eye was 6.6. Anterior segment examination revealed an whitish iris nodule extending from 2 o'clock to 5 o'clock with no surface vascularity. AC was relatively quiet and fundus examination was within normal limit. There was no relevant past history and UVA workup was done. On 1 week follow-up, hemoglobin was 8.2, ESR was 89 and MANDO was found to be positive. However, what we noticed that there was a sudden increase in size of the nodule with surface vascularity. We also noticed multiple small whitish nodules on the surface of the iris. For diagnostic confirmation, we went ahead with QTB and HRCT. QTB was negative and HRCT showed multiple nodules in lung with supraclavicular node and suggested biopsy. During this visit, we noted multiple new vessels on the surface of the iris with an elevated IOP. So we went ahead with biopsy of the supraclavicular node, and to our surprise, it revealed metastatic adenocarcinoma and suggested immune IHC. Emergency oncology referral was done and they went ahead with PET-CT. Tumor markers except CA19-9 was negative and IHC report was pointing towards either a lung primary or an upper GI primary. PET-CT also revealed extensive metastatic disease with ocular involvement, hepatic and pulmonary involvement. Next generation sequencing was done to find out the primary, and the final diagnosis came out to be metastatic adenocarcinoma stage 4 hepatobiliary carcinoma. We went ahead with palliative chemotherapy, and while the patient was on chemotherapy, he came to us with a sudden visual decline. Best corrected visual acuity has dropped to counting finger 1 meter. There was total hyphema and there was no fundus view. B-scan was done and it was within normal limit. Patient continued chemotherapy, and during the chemotherapy, he came to ER department with sudden respiratory distress, and finally the patient succumbed to the metastatic disease. So going to the second case, it's of a 68-year-old male who presented with redness in left eye of 2 weeks duration. He was treated outside with conventional treatment but was not responding, and AC tap was done from the outside center. He gives history of TB. ATT was taken 3 years back and recent UTI. Left eye clinical image, showed a small iris nodule at 2 o'clock position with overlying fibrin membrane. Fundus B-scan was within normal limit. The lab reports were negative and aqueous aspirate analysis reports also came, which came out to be negative. So we went ahead with HRCT, chest and abdomen, which showed multiple granulomatous lesion. So a thorough systemic evaluation was done and multi-specialist opinion were sought to identify any foci of active infection, but all came out to be negative. Since the patient was not responding, we went ahead with the surgical procedure, that is the excision of the iris lesion. And on post-operative 3, the patient was doing well with best corrected visual acuity of 618. Inflammation was subsiding and the AC10 vitreous tap report came as negative. On post-operative 7, patient revisited, the AC reaction was getting better and best corrected visual acuity has improved to 612. During this visit, we got the histopathology report showing caseating granuloma, suggestive of a tubercular granuloma. On post-op day 14, he came with all the reports, vitreous culture, molecular testing and urine analysis, all of which came out to be negative. So on post-op day 16, the visual acuity was 6 parts, the eye was looking pretty well, and the fundus was within normal limit. So the take-home message is that whenever we see an atypical iris lesion, it warrants metastatic evaluation, and when in doubt, histopathology is the gold standard. So I'd like to conclude my talk by asking a question to the panelists, whether we should have started ATT in that case.
Thank you, Needu. So we have 2 iris nodules. One turned out to be TB and one turned out to be metastatic. So first I invite Dr. Anuradha, how to differentiate an infective pathology from a metastatic iris nodule. Any key?
Okay. Can you hear me? Yeah. So you have a similarly aged patient, patient in their late 60s, presenting with what looks like very similar iris nodules in this case, but turning out to be one turning out to be TB and the other one turning out to be a MET. So in the first case, what you should note is that, in spite of the lesion being there, the patient was asymptomatic. There's no AC reaction, there's no pain or redness, that itself is a big clue. The second thing I want to tell is, we sometimes should not forget our very basics, in that whenever we have iris nodules, you are suspecting a malignancy or a TB, you should look for cervical lymphadenopathy. And very often, doing a biopsy without doing an invasive procedure in the eye. Now, in this case, when it's in the anterior segment, it's relatively easy to biopsy the lesion, but if it's in the posterior segment, it's a totally different ball game. But if you can locate an enlarged lymph node, it might be pretty easy to get your diagnosis from that. And the third point is, whenever you have need to differentiate between TB and a malignancy, I think you should do HRCT in the first place, not the chest X-ray. I think those are the main points.
And the second question, whether a patient already treated with ATT before presenting with TB uveitis, when to consider repeat ATT?
I think in this case I would, because it's been a few years and you all know that TB can reactivate. Unless it has been a recent ATT, say in the last 2 or 3 years, and you have ruled out drug resistance, then in that case, I would not repeat the ATT. And you have ensured compliance and you have ensured that the patient has taken ATT for the recommended period of time, which is at least 6 months.
Yeah, drug compliance is very important. You have to take history again. And drug resistance, how to, whether it's pulmonologist decision or ophthalmologist decision?
So in real life scenario, actually, like when you clinically suspect TB, you have corroborative evidence. In the past, have taken vitreous sample and send it for drug-resistant testing. But almost all the time it has actually come out negative. Negative even for TB. I think when it comes to ocular TB, it has to be the ophthalmologist's decision. So unless, clinically you feel, that it's progressing and you're suspecting drug resistance, I think most people nowadays would just, take the chance and then move on to immunosuppression. Yeah. Unless you are suspecting a frankly infectious tuberculous uveitis.
Thank you, Madam. Dr. Archana, you want to add any points?
I just wanted to add, but Dr. Anuradha already mentioned it, that you shouldn't be well, rather you should consider as an inflammatory element, not just infectious reactivation. So yes, multi-drug resistant TB and with careful consideration along with the pulmonologist. If that's not the case, then definitely you should be considering like an antigenic inflammatory element as well, obviously treated with immunosuppression. Thanks.
Thank you. So to summarize, how to differentiate between an infective TB, TB iris nodule from metastatic nodule. On clinical examination itself, you can clearly see, like, in metastatic cases, it will be like deposits, vascular deposits. There won't be any KPs and all. There won't be much AC reaction and all. And history taking is also very important, and those deposits won't resolve with topical steroids alone. And proper systemic evaluation, communication with the physician, with all this we can differentiate and we can save the patient also. Thank you. Next I invite the next speaker, Dr. Anshu Kuriakose from Chaitanya Hospital. She will be presenting a case of TB vasculitis.
Good morning to one and all present here. I am presenting a case of a 35-year-old young male came with sudden onset blurring of vision in his right eye for the past 2 days. No history of headache, redness, photophobia. No history of relevant past history or drug history. No positive uveitic history. No history of TB, PETs, oral or genital ulcers, recent fever or cough. On examination, his best corrected visual acuity was 6.6 and anterior segment 1+ L's, otherwise within normal limits. Fundus of the right eye showed disc hyperemia with vessels tortuous vessels along all 4 quadrants with perivascular sheathing and significant retinal hemorrhages inferiorly with neovascularization with yellow elevated lesions in all 4 quadrants. Similarly, in the left eye, vessels were tortuous with retinal hemorrhages more extensively in the left eye with perivascular sheathing. Montage of both eyes on the first presentation. OCT over the choroidal lesion revealed a well-defined elevated choroidal lesion with heterogeneous reflectivity with RP elevation and outer retinal layer disruption suggestive of a choroidal granuloma. The provisional diagnosis of bilateral occlusive retinal vasculitis, predominantly periphlebitis with choroidal granuloma, was made. The patient was started on topical steroids, sent for blood investigations and planned for FFA ICG. He was reviewed with blood reports. All were normal except ESR. We went ahead with the ICG of the right eye showed multiple hypocynoscent areas scattered over the posterior pole, suggestive of a choroidal granuloma. FFA and ICG showed hyperfluorescent spots which is increasing in size and intensity with showing capillary non-perfusion areas in the periphery in all 4 quadrants. Late phase showing extensive perivascular leak. Similarly, in the left eye, it was more predominant than the left eye, the more extensive leak and the CNP areas. Late phase showed extensive perivascular leak. Based on this FFA ICG, our first provisional diagnosis was sarcoidosis, seeing the multiple choroidal granulomas. Second was TB and the mimicker syphilis. So we went ahead with the more relevant investigation of QTB, which was positive, and AS and HRCT was normal. So the diagnosis of bilateral tubercular posterior uveitis was made. We sought the pulmonologist's opinion. So according to the COTS criteria, ATT was initiated with 6 months regimen. After 3 days of initiation of HGD, patient came with complaints of right eye pain and watering, which showed diffuse, anterior segment showed diffuse congestion and edema superiorly with tenderness. Fundus shows hyperemia of the disc with circumscribed yellow elevated lesions temporal to the disc with SRF. B-scan revealed classic T sign. Diagnosis of right eye posterior scleritis secondary to TB was made, which is considered as a paradoxical worsening of the disease after starting the ATT. So he was started on oral steroid 1 mg per kg and reviewed after 1 week. Posterior scleritis had resolved with resolution of hemorrhages. This is fundus picture 1 week after ATT and steroid. FFA guided PRP was done under steroid cover and ATT. Thank you.
Thank you, Anju. Over to you, madam. How to proceed if you see a case of periphlebitis?
So in this, so whenever you see vasculitis, it's very important that you look for focal lesions because the implications are different. So if you see choroiditis or retinitis along with vasculitis, there's a high chance that you're looking at an infectious process rather than only vasculitis. So that's the first point. I'm very happy you did combined FFA ICG rather than FFA alone. I'm a strong advocate of doing a combined ICG for baseline, at least for baseline when you suspect a choroidal involvement. You didn't start, when did you start the oral steroids in this case?
After we saw this posterior scleritis.
Is there any reason why you didn't add steroids?
The patient was advised to come after starting of ATT to start the oral steroids after 2 days. But then on the third day, patient came with pain. So it was supposed to be started on the same day.
Right. So we have seen cases, of presumed ocular TB, but those are usually solitary granulomas, where we have asked the patient to start ATT and then come back for oral steroids, but the patient has actually come back after 6 months with resolution only with ATT. But the thing is, for most cases, especially I think when there is an element of vasculitis and it's a multifocal choroiditis, you have to combine it with steroids. So paradoxical worsening is well known in tuberculosis. And the pattern in which it most commonly happens is the serpiginous, like choroidopathy. This is a little bit unusual, but it can happen. Yeah, so for almost all my cases, I would combine ATT with steroids.
And how to differentiate between an infective vasculitis or is it an immune due to TB?
Yeah, so that's the eternal question, and I think, we are nowhere near, answering that question. But how much of it is the infection and how much of it is an immune-mediated problem? It's a huge challenge. Because I'll tell you an interesting case I've seen, a long time ago. That patient actually came with periphlebitis, an occlusive vasculitis in one eye. And I went back and looked at the previous records, where they had consulted somebody else in another hospital. And, surprisingly, in the same area that patient had choroiditis before, which had disappeared, and was now presenting with vasculitis in the same area. I believe, this is from my personal experience, I believe that the vasculitic component in TB is mostly immune-mediated, whereas the granulomas, they tend to be more of infective. But having said that, I'll also tell about one more patient of mine, who came with what looked like pure vasculitis, no choroidal lesion, no paravascular lesions. I asked for, Manto was positive, I asked for clearance and I started high-dose oral steroids. He responded, and then he comes back with slurring of speech and difficulty walking. He actually developed a very extensive CNS TB, and it took more than a year, to bring the disease under control. So you need to be really, really wary.
Thank you, madam. And Dr. Archana, how you treat TB vasculitis there, or is it like it's no TB there?
There's no TB.
UK.
Of course we do, especially with the globalization and stuff. We are seeing more and more cases of TB. So it's always a multidisciplinary approach along with the pulmonologists who are interested in TB and other infectious diseases. I'm of the strong advocate that we need to definitely combine both ATT and steroids. And my colleagues are very supportive in the sense that they try to get to see the patient as soon as they can, because it's a long waiting in the UK, in the NHS setting. So how I would approach a case as to decide when to start the systemic steroids is by looking at whether there is any vision-threatening elements. If there is any vision-threatening elements, then I'll liaise with the TB physicians and say that I do not have time to start the ATT on the same day. They might not be able to see the patient on the same day, but I start the systemic steroids, depending if it's a vision-threatening element like macular edema or severe papillitis or extensive posterior pole vasculitis, and initiate the ATT within the next day or so. In this case, because the vision was 6.6, although there was some discongestion, I would not have possibly started the steroids straight away without the ATT cover, because we can actually wait for the ATT and start the steroids, simultaneously after starting the ATT, because there wasn't much of a vision threat. The other thing I wanted to ask was, did you actually investigate along the lines of syphilis and HIV?
Yes,
and
yes,
HIV
everything
as
was
well.
done before
Okay.
starting ATT.
Yeah, so just to add that you need to consider the possibility of whether this is syphilitic and also HIV in these cases. Thank you.
Thank you. So to summarize, whenever you see suspected unilateral or bilateral vasculitis, do proper imaging and confirm the extent of vasculitis, involvement of arteries and veins, and proper communication with the pulmonologist. If you suspect TB, do communicate with your pulmonologist and consider ATT. Okay, thank you. Next, I invite Dr. Rehna Rashid from Amrita Hospital. She will be presenting a case of retinitis.
Good morning, and thank you, Dr. Risha. So it's a disguised ocular toxoplasmosis. So my patient is a 20-year-old female who presented with progressive blurry vision and floaters in the left eye for the past 6 months. So her history is 6 months back she had started these symptoms and she was evaluated outside, found to have uveitis and was started on systemic corticosteroids. Medical background, there's a history of suspected SLE as per the patient, which was diagnosed 3 years earlier and started on medication, but she didn't continue. So this was her treatment course before coming to us. She had a vitreous stab done and gram stain and KOH was negative. No further results available. She also had 2 doses of intravitreal triamcinolone 3 months apart. And 1 week before her visit to us, she was given Bactrim, which is a combination of sulfa and trimethoprim. And she developed cutaneous rashes, facial swelling, and elevated hepatic enzymes, which required medical admission. So that was suspected sulfa allergy. So on examination, her visual acuity in the right eye is 6.6 and the left eye is 6.9. Anterior segment right eye was normal, intraocular pressure was normal, and the left eye, there were cells in the anterior chamber, and visual acuity was 6.9. Intraocular pressures were fine. Fundus in the right eye, there was a chorioretinal scar infranasal to the disc. And in the left eye, the disc was blurry, there was extensive retinitis with hemorrhages, vessels were sclerosed, and the retinitis were extending to the mid-periphery and beyond. There was a scar superiorly with some pigmentation around. There were some deposits of triamcinolone which was seen inferiorly in the fundus, and there was very mild, that is grade 1 vitritis. OCT, there was no enema. We could confirm this whitish opacification which is due to the retinitis superior to the disc. So at this point, the differential diagnosis were acute retinal necrosis, CMV, and ocular toxoplasmosis. ARN, but there was no vitritis, but extensive retinitis was there. In CMV, usually presents in patients who are immunosuppressed, which this patient was not. and it has a granular appearance compared to our patient which had a thicker retinitis. And ocular toxo was considered because of the presence of the scar in both the eyes. But the atypical feature was that there was no vitritis and the retinitis was extensive, unlike the toxoplasmosis, can occur in immunosuppressed. So she underwent vitreous biopsy, and the sample was sent for HSV, VZV, that is varicella zoster, CMV, which was found to be negative. Toxoplasma came to be positive, and serologically also toxo IgG turned positive. So she was diagnosed to have retinitis due to toxoplasma. So she was started on treatment with Clinda 600 TID. Sulfur was not given due to suspected allergy, and pyrimethamine wasn't available. So steroids were continued, topical steroids were continued. Because of the past history of this SLE and all, she also had a rheumatology evaluation where ANA and anti-dsDNA was found to be positive. Their clinical diagnosis is undifferentiated connective tissue disorder, and methotrexate was also started. So this is her after 2 weeks of treatment. You can clearly see that the retinitis is improving. There is this area, and this area has improved a lot, but still significantly it is there, but the vitritis started to get worse a little bit. So this is at 6 weeks. This is the initial picture, and this is at the 6 weeks picture. So we can see that definitely retinitis have come down, but still there at 6 weeks, and the vitritis has worsened, and the visual acuity from 6.9 has dropped to 6.18. So this is her last picture, the last follow-up, and she's yet to come for further follow-up. Here we have advised, maybe she was on tapering of steroids, so increase the steroids and intravitreal clindamycin, but she hasn't come yet. So I reckon this patient probably would have presented with a phenotype of autoimmune kind of posterior uveitis and was started on steroids, but with the presence of steroids, the toxoplasma would have reactivated, and with the intravitreal triamcinolone, it would have spread relentlessly to have an atypical picture like this. So I would like to ask the expert panelist whether we should have done differently, or how should we go further with this patient. Thank you.
Thank you, Dr. Rehna. Madam, your opinion regarding this ARN-looking toxo lesion?
Okay. I have a very similar case. Okay? Yeah. Same thing, you know, given IVTA twice and presenting with very extensive atypical toxo. So what was the indication for giving IVTA? What was the indication?
I think probably the patient would have presented kind of a posterior uveitis kind of picture. We don't have the initial picture with us.
Right.
So
Nothing from the notes either.
only some papers which say what the procedures were done. That's
Not
all.
the indication as such. No findings. as
Most
such.
likely that small retinitis lesion might have missed.
Yeah.
And considering it as intermediate uveitis, they might have given.
And with the history of autoimmune disorder, that
Yeah.
probably would have been taken as an autoimmune kind of thing.
Can you go back to the initial slides where you have put ARN versus CMV versus toxo? So the first thing is that, you know, like, do not make the assumption that, you know, because a patient has a systemic autoimmune disease, that whatever uveitis that comes to you is directly related to it. On the other hand, I think if the patient is already immunosuppressed, you know, if the patient is on immunosuppressives or steroids, you need to really worry about infection, right? The second thing is, if you ask me whether this is ARN, this is not the picture of ARN. ARN's lesions start in the periphery. Okay, this one is in the mid-periphery. So that goes against ARN. Can you come back to
This is
the
initial.
Yeah. And the fact that, you know, there are scars in both the eyes, again, should have been a clue. You know, there's one in the right and one in the left as well. Next one. Go on. Hold. Go back. Hold. CMV retinitis, you know, happens most commonly in immunocompromised patient, but you also should know that there's something called local immunosuppression. If you give IVTA or a deposteroid into the eye, it is... It's okay. It's well known that, you know, you can get reactivations of toxo or even viral retinitis. So I think the clinical picture, actually favors atypical toxo, and you did the right thing, going ahead with the vitreous biopsy and the PCR. The only thing is a lesion like this, I think needs combined therapy, with systemic as well as intravitreal clindamycin, and I would also give dexamethasone. My patient also, had the same problem of the vitritis, worsening, as we tapered the steroids. So we have actually managed with combined therapy.
Okay, ma'am.
Serial intravitreal clinda with dexa along with my patient was okay with Bactrim, so Bactrim and systemic therapy. So the take-home message is, be very, very careful, injecting depot steroids into an eye when you're not sure of what lies behind. And the other thing is, the patient was referred for rheumatologist evaluation.
The patient was actually presented to a hospital as an emergency with the facial swelling and all, and then was referred. The patient was referred to
Self-allergy, they suspected.
Yeah, but the patient was diagnosed as CTD, right? Connective tissue.
undifferentiated connective tissue.
That is because ANA was positive and
Yeah, yes, ma'am.
ANA and dsDNA were
Was
both positive. Yeah, so when you're trying to manage infectious uveitis and the patient also has systemic immune-mediated disease, you really have to get in touch with the rheumatologist. I would have actually advised them to defer methotrexate and used only steroids, to control the disease. Yeah. I would have waited for a good clinical response and then, ask them to start methotrexate if needed. Although methotrexate is very slow acting, it takes about 3 months for it to act. But even then, in such a situation, it is better to use steroids to control the inflammation in the eye. And there's one more thing. And you need to put this patient on Bactrim prophylaxis.
Bactrim.
Prophylaxis.
Okay, but this patient is, I'll have an
Oh,
allergy
yeah,
to
sorry.
sulfur.
I missed that. If she wasn't, if this patient wasn't, then definitely needs prophylaxis.
Okay.
Which drug? Azithromycin or clean?
So if there is sulfur allergy, because this patient is going to be on metho probably for a long time, so just continue with azithromycin then because of the sulfur allergy.
Use azithromycin, but if the patient was not allergic, I would definitely put the patient on Bactrim prophylaxis.
And close follow.
Thank you.
And Dr. Archana?
I have used azithromycin prophylaxis in patients with sulfur allergy, so just 500 milligrams once a day for like 3 days a week, so alternating, or sometimes even 250 milligrams, because as a prophylaxis dose I'm taking, sometimes it can be quite difficult on the tummy. Patients have actually reported like gastric discomfort. So, what was the patient's intraocular pressures on presentation?
It was normal.
Normal, okay. It's just that when you can also get clues if the patient presents with hypertensive uveitis, it's mostly pointing towards a viral etiology or toxo. So be aware of that. So high intraocular pressure with posterior uveitis or any uveitis, so to say, is pointing towards an infective etiology. And please stay away from injecting any intravitreal steroids without ascertaining the diagnosis and ruling out infections. And you shouldn't be hesitating or have a very low threshold in doing a TAP. And especially in immunocompromised patients. This patient, I believe she stopped the methotrexate, didn't she? And then she was not on any immunosuppressants.
No. Not
Again, if any patients on immunosuppressive medications or immunocompromised patients, so to say, like patients with HIV, etc., or malignancy, so to say, you definitely need to do a vitreous TAP because you could be dealing with mixed infections as well. So it might not be just toxo or just virus, it could be dealing with a mixed infection. So just to highlight the point that you definitely need to consider the TAP. Yeah, thank you.
Thank you. So to summarize, before labeling a patient as anterior or intermediate uveitis, do a thorough indirect ophthalmoscopy and rule out any infectious pathology before treating a patient with intraocular or periocular steroids. Thank you. Next, I invite Dr. Natasha Radhakrishnan. She will be presenting yet another case of retinal vasculitis, but with a different etiology.
It's good to be in the main hall with uveitis, which is a welcome change in Ksos Drishti. I will be presenting a 36-year-old male with right eye flashes and floaters with no history of fever or joint pain. Vision was 6/6 N6. Intraocular pressure was normal. Anterior segment was within normal limits except for anterior vitreous cells. And the right eye showed patchy venous vasculitis along the inferior arcade with a few round yellow patches and hemorrhages and venous vasculitis elsewhere as well. The fluorescein angiogram showed right eye with slow filling infrotemporally and supratemporally with perivascular leakage, mild decrease in perfusion in the later frames with a mild disc leak, no other areas of vasculitis. Left eye there was no vasculitis or disc leak, and the OCT was normal in both eyes. Patient was started on topical steroids and cycloplegics, and 1 week later vision dropped to 6/9. Pulmo consultation was sought to rule out sarcoid TB, and the blood tests were sent. These are the blood tests which most of it just came out negative. And patient was also started on oral steroids, 60 milligram. And the pulmonology came back as IgM positive for aspergillus, for which the pulmonologist started on itraconazole. For us, what looked like those yellowish retinitis patches were not visible on the fluorescein, so I was not able to distinguish what kind of patch they were. And that appeared to be resolving with some patchy sheathing of the vessels, and the hemorrhages were persisting. So on the cover of itraconazole, the oral steroids were tapered and stopped, and the 6/9 improved to 6/6. But after stopping the oral and topical steroids in 1 month, he came back with a very similar looking picture with multiple hemorrhages and more active vasculitis. And again, those few yellowish round lesions infronasal to the disc. And the hemorrhages started increasing in the temporal periphery. Vision was at 6/6 parts. So it was a recurrence when the steroids were stopped. In the meantime, I restarted oral steroid and sent the patient back to the pulmonologist and discussed with him whether this aspergillus is actually relevant or not. He had refused a PET CT earlier, and so this time he underwent a PET CT, and a variable hypermetabolic small prominent lymph nodes were found, and they decided that it looked like a granulomatous disease. The repeat fluorescein showed this time more in favor of sarcoid, and the aspergillus apparently sometimes comes out positive in these bronchoalveolar testing. And I repeated the fluorescein because the vasculitis looked much more extensive than before, and you can see that now more posterior pole vessels are involved, and there is significant CNP areas also in the area of the vasculitis. With a systemic diagnosis of sarcoidosis, we stepped up oral steroids, and the pulmonologist added immunosuppression at MMF. And I did a sectoral PRP to the area of the right eye in the non-perfused area. And a repeat PET was done, which showed the lung nodules decreasing in size. The oral steroids were tapered, and patient was put on maintenance. And the patient is doing well with minimal coarse vitreous floaters, and the lasered areas are stable. There is no active vasculitis in either eye. This is the OCT at last follow-up with just a minimal epiretinal membrane. He continues to maintain best corrected visual acuity of 6/6, and he is continuing the immunosuppression. So like the previous case, I just wanted to highlight that many times what you get in your investigation is probably a red herring, and a non-response to treatment or recurrence on treatment should alert us that we are looking at some other diagnosis. And in any time in a uveitis treatment, you should be prepared to revise your diagnosis on the way. And here what saved the day was me picking up the phone and calling the pulmonologist and asking him, how relevant is that aspergillus in your lung? And I don't seem to have it in the eye. And so both systemic and local treatment should go hand in hand. Thank you.
Thank you, Dr. Natasha. Daily we see lots of vasculitis patients. Some are like occlusive vasculitis, some are autoimmune related, some are TB, sarcoidosis, some will be like post fever. So can you give some tips? Yeah, to Dr. Archana.
So basically, you start from the basics. You need to take a thorough history from the patient before you plan your investigations and then basically putting the puzzle together. So first of all is thorough history, thorough examination, and see the patient as a whole rather than just the eye. So see the patient as a whole, and again, don't hesitate to get input from physicians, and you rightly did that, Natasha. And they can help with, adding investigations, etc. The third thing, these are just, general things. I'm not going to dwell deep into stuff, but the third thing is, before interpreting or even ordering the investigations, you need to be aware of the sensitivity, specificity, predictive values, etc., which I'll be covering in my talk. So if you look at the predictive value of the positive aspergillus in this test, it probably is very low. Therefore, you need to consider a different diagnosis. And again, lastly, but not the least, phenotypic recognition of the entity, and then try to see which condition we are dealing with. For example, birdshot chorioretinopathy, you can have associated vasculitis, but usually you do not get the macular edema. Sorry, the other way around. So vasculitis with no macular edema, you should be considering even lymphoma in those kind of patients. So pattern recognition and aiding diagnosis with pertinent points from history, systemic examination, and relevant investigations. There's no easy answer. There isn't any, there is no textbook cases when it comes to real world.
Yeah, when the pattern, with the pattern recognition, I was quite clear that this is probably not aspergillus in the eye. Correct. But with systemic aspergillus being treated, to put the patient on a full immunosuppression would may have disastrous consequences. So I was hesitant and just stayed with the steroid for a while.
Yeah, thank you.
So like I was saying in the first vasculitis case, I recommend you do ICG along with FFA. I think that's something that might have helped you in picking up the underlying choroidal lesion. Yeah. Was serum ACE done in the first?
It was normal.
It was normal.
Continues to be normal.
Yeah. There again, it's not a very sensitive or specific. Yeah, that's all. And you really need to learn how to separate the wheat from the chaff. That comes with experience. Yeah.
Thank you.
I would also like to invite everybody for a dedicated uveitis meeting in Kochi in January, 10th and 11th of January, Ignite, which is very familiar to all of you. Please do come. Thank you.
Thank you. Next, I invite Dr. Archana Pradeep. She is a consultant ophthalmologist at Nottingham University Hospitals. She is a dedicated uvea consultant and a phaco surgeon, and she is also a training program in charge of East Midlands Ophthalmology Hospital. Okay. Over to you, madam.
Thank you, Risha, for the kind introduction. And thank you, Ksos, for inviting me and giving me the opportunity to be part of this remarkable conference. Can you hear me well there? Okay, fine. So when Risha asked me to present uveitis management and guidelines, I felt a bit challenged because, as you all know, it's quite a fairly vast topic, and to squeeze it into a 10-minute session can be a bit challenging, but I am undertaking that challenge for you, Risha. Anyway, so uveitis, as we all know, is correctly used, a term that's correctly used to describe inflammation of the uveal tract. But in reality, it encompasses a wide variety of inflammatory conditions affecting not only the uvea, but also the retina, optic nerve, and vitreous. And the prevalence of uveitis varies according to the geographical location, and 10 to 15% of the cases of total blindness worldwide is attributed to uveitis. And it can cause significant socioeconomic impact as it mostly affects the working age group patients. So how do we define uveitis? It can be quite a confusing process because it can be approached in a multi-pronged fashion, and also with more and more newer terms being progressively added to our lexicon. Actually, coming up with a definition can be sometimes a bit perplexing. So you can define uveitis according to the anatomical area affected, like anterior, posterior, intermediate, so to say behavioral, like acute, chronic, recurrent, etc. Etiological diagnosis, depending on the etiology, as in whether it's infective, non-infective, masquerade, idiopathic, eponymous definition like Fuchs and Posner-Schlossman, descriptive like punctal innate choroidal retinopathy or BSCR, and speculative like presumed Behçet's and possible sarcoid. So when you approach a case of uveitis and to diagnose and manage, you need to be very systematic and thorough and make use of all these entities to come up with a sensible diagnosis and management plan, making sure that you quantify the disease and see whether, first of all, whether you're dealing with a sight-threatening and or a life-threatening condition as well, because as you all know, systemic associations can be common in uveitis. I'm not going to go into detail regarding the anatomical classification, etc., but just wanted to get across this point because I've seen time and time again, referring clinicians saying that this patient's got posterior uveitis, but in fact, they are just having an anterior uveitis, which is complicated with macular edema or reactive papillitis, so to say. So the classification should be based on the anatomic site, but not based on the structural complications. Just going to skip through those because I'm sure you're familiar with all those. Just to get across that, please grade, quantify the disease, measure the disease. So grading you can do with all the scoring system right from the baseline presentation and throughout the reviews so that you can see whether the patient is responding to treatment and whether you should be changing your management. So please do document it and quantify the disease. It is worth spend the time. Right, so how do we investigate uveitis? Or so to say, any clinical entity? Your principle should be minimum investigations giving us maximum information. So please don't throw a whole lot of battery of tests and you will be baffled because you'll be having to deal with a lot of false positivities, negativities, etc. So minimum investigations giving us the maximum information. So stick to general tests common to most uveitis patients and specific tests relevant to particular type of uveitis patients. So as I mentioned when Natasha's talk was going through, we need to be aware before ordering an investigation, see whether this investigation is going to change my management or is it going to add an impact in this patient's care. And so therefore you need to be looking at the sensitivity, specificity, the positive and negative predictive value, and then interpret along with the history and the clinical signs to build up the diagnostic confidence that you are actually diagnosing this patient correctly. So for example, there are different levels of diagnostic confidences like confirmed. For example, if you are having a confirmed microbiology or a histopathology report, you have a confirmed diagnosis. Presumed when you have strong supportive evidence and possible with no other evidence of another diagnosis, especially very much like Natasha's case. So there was no evidence of another diagnosis, it's possible sarcoid, okay? And we don't have the tissue diagnosis for confirmation. So what are the baseline investigations that we should be doing in a case with uveitis? I'm going to come to that in the next few slides, that not all cases of uveitis needs investigating, but if you are considering to investigate, what are the baseline investigations that we should be doing? So we have to start with full blood count, liver function tests and kidney function tests, although it might not be giving any clinching diagnosis, but it does give us ideas as, for example, eosinophilia in parasitic infection, lymphopenia in sarcoid, so to say, or neutrophilia in bacterial infections, etc. Liver function tests, it might be elevated in sarcoidosis, for example, if there is liver sarcoid. But again, that is a good practice because you can get a baseline result if we were to start immunosuppression at a later date. ACE, angiotensin converting enzyme, even though it's not a very sensitive or specific test, we still do include them as a baseline investigation, and anything above 100 has got good correlation with sarcoidosis. Syphilis, again, is a great imitator, so please do include syphilis in your baseline investigation. Urinalysis, such a simple, non-invasive test, but giving you worth a lot of information. And of course, also a chest X-ray. I did, listen to Dr. Anuradha's suggestion about HRCT, but in a UK setting, we will have to do chest X-ray first before to prove whether we need to do HRCT. Sometimes we might not pick up fissural, periphyseal nodules and stuff in chest X-ray, but then I can, if the patient is symptomatic or if I can argue the case for an HRCT, then I can go ahead. But that's not as considered as a first line, just because of the NHS setting. Specific investigations, I'm not going to go through all this, but again, it will be history-oriented and clinical examination-oriented. For example, ANCA, toxoplasma, antibodies, quantiferon, etc. MRI head in demyelination, lymphoma, and neurosarcoidosis. And of course, chorioretinal biopsy and vitreous biopsies as the case may need. So, when to investigate a case of uveitis? So, unilateral acute, new or recurrent, non-granulomatous anterior uveitis. In a fit young adult, no investigations are required. But it is a bit difficult to ascertain whether that patient you're dealing with is a fit young adult. So it might need a bit of a work before you can actually, label a patient as fit young adult. So most of the time people tend to just investigate because they can't be bothered, but you should be taking the effort so that you can prevent unnecessary investigations and then all these kind of false positive tests or whatever it is. A bilateral simultaneous anterior uveitis of any type or a granulomatous unilateral anterior uveitis in a fit patient, you still should investigate, starting with the baseline investigations that I mentioned. Intermediate uveitis again include the baseline investigation, but only consider neuroimaging if the patient has neurological symptoms or signs. So there's no point in just ordering neuroimaging, because most of the time intermediate uveitis can get reactionary papillitis element, and that might not be, something to worry about, and it will respond to treatment. But if there are any neurological signs, or if you're dealing with an elderly patient, please do consider neuroimaging. Acute unilateral panuveitis, yes, you definitely need to investigate, and also even consider doing a blood culture, vitreous tap and echo to rule out any endogenous sources. Necrotizing retinitis, of course, again, baseline tests with a supportive tap results. Posterior uveitis and retinal vasculitis, as I mentioned, again, it's pattern recognition with directed investigations like TB testing. And also in patients in whom you're suspecting an underlying disease, please do not hesitate to refer to a physician, as they might require more detailed or invasive investigations. So what are the general principles of uveitis management? So set targets for achievement. That's why it's important to quantify and measure the disease. gain patient understanding. You need to develop that rapport with your patient, because as you can see in those cases that you presented, some patients are not adhering to the treatment, they just stop. They might not be knowing that these are chronic conditions which need lifelong, fairly lifelong treatment, and that can modify their systemic risks, etc. So time spent is well worth spent, because the patient compliance is important. It actually will help you. Anyway, so I'm gonna, again, also please don't forget dealing with visual loss. You might have to support the patients with rehabilitation, etc. So treatment, again, mainly medical and surgical. Medical, as you know, with steroids, topical or periocular, intraocular, and systemic. And then the second line would be immunomodulatory treatment if they are not responding to steroids, or we can't maintain remission with lower doses of steroids. And surgery in uveitis patients, as a general principle, you need 3 months of quietness, and we might have to condition them accordingly in their pre- and perioperative periods, and also close post-op monitoring for flare-ups, and continued remission might be required. And these cases can be quite challenging as well surgically. Just wanted to go through a quick flow chart for managing non-infectious anterior uveitis. So if it's anterior uveitis, you look for, are there any structural complications associated with it, like macular edema? If there is, then you treat with systemic and topical steroids, of course, after ruling out infections. If there is no macular edema, then you treat accordingly with topical steroids, and might need staged mydriasis or subconjunctival steroids to break the posterior synecdoche. And none of them working, then you might have to escalate to the systemic route. Just to highlight this point, that if the patient is having more than 3 episodes of anterior uveitis per year, please do consider uveitis specialist referral for consideration of immunomodulatory treatment. Intermediate uveitis, again, if there is dense vitritis, if there's macular edema, again, you treat accordingly with systemic steroids or periocular or intraocular steroids. If there is no macular edema, and you look at if there is vitritis causing reduced vision. If there is, again, you go down the other route to systemic steroids. If not, you can just use topical steroids. So basically, if there is no vision-threatening element, observation might be considered as well. Do I have time?
Time is over.
Yeah.
One more slide.
One more. I'm just gonna...
No. Time is over.
Time is over. Okay. Just wanted to show you quickly one slide about the newer developments. So newer and newer targeted treatments are coming along, biologics and biosimilars, and the role of gut microbiome, which is the gut-eye axis, has been extensively explored, and it is the era of precision medicine. But at the same time, we need to look at the cost effectiveness and feasibility. So all these microbiome signatures and the cytokine profiling, whereby you can see many of the uveitic entities have like unique protein profiling and some common cytokine signatures. Some of the microbes in the gut can actually act as risk factors or even confer prevention of uveitis. So all these are exciting areas coming along, and actually we can, using all these together, pool data, we can actually even prognosticate whether this patient is going to get relapses, are they going to respond to particular treatment, etc. So just about the precision medicine, and I'll be done. So when we have the same patient with same diagnosis and they receive the same treatment, we do have some people responding to the conventional treatment and some people not responding to the conventional treatment. People who are not responding to the conventional treatment, with the new proteomics, metabolomics, all those pharmacogenomic testing, you can actually determine their genomic profiling and see why they're not responding, and then develop targeted treatment to treat. So future is bright. And with all these novel technologies emerging, we would be able to deliver not a reactive, but a proactive, predictive, and personalized treatment for our patients. Thank you for your time.
Thank you, Dr. Archana. Now I invite Dr. Nadasha Radhakrishnan for giving away the memento to Dr. Anuradha. and Dr. Rehna, to give away the memento to Dr. Archana Pradeep.